Great. Thank you, Maricel. We're going to get started. Okay, great. So welcome, everyone, and thanks for joining us today for this session on structural competency, a framework to analyze and address social determinants of health and health disparities. I am Sonia Lee. I'm with Health Outreach Partners, and I'll be one of our presenters today. We really appreciate that you're participating and wanting to really delve further into social, economic, and political structures and really seeing the impact that it has on health. And just given this unprecedented moment that we're in with the COVID-19 pandemic, I think we've seen how it's more important than ever to really get at understanding why folks are vulnerable, why people are at risk, and really the root causes of a lot of these inequities, especially for communities of color. And so we're really hoping that you're going to leave today with this broader understanding of structures and have this lens and this shared language to be able to better serve and as well as advocate for your patients and communities. So again, I'm Sonia and I'm with HOP and I'm joined today by Liam Spurgeon, and he'll also be presenting with me. Next slide, Liam. So for those of you, just quickly, if you're not familiar with us, we're Health Outreach Partners, or HOP. We're a national nonprofit. We're based in Oakland, California. I often say we are advocates of outreach because we see the important role it really plays in connecting to vulnerable and underserved communities, as well as really building that trust in relationships and facilitating access to care and other social services. So you can see our mission is really to build strong, effective, and these sustainable health outreach models. We do this through trainings, consultations, as well as the provision of different key outreach resources. We primarily work with health centers, PCAs, as well as other safety net organizations. So you see our website is on screen, and I encourage you to visit it. We have a lot of good resources. Next slide, please. So this is a 90-minute session. This is what we're going to be covering today. We're doing the welcome and intros, and then we're going to really go into what we really mean by structures. Then we're going to look at these concepts around structural violence and racism, as well as white supremacy. We'll do a case study together, and that's when you all will go into breakout rooms. And then we'll conclude it with looking at what we call structural interventions, what kind of actions you can really take, and we'll have a short time for Q&A and closing. And then I just want to acknowledge that the content that we're sharing today is really based on a curriculum from the Structural Competency Working Group, who worked together with us in adapting the curriculum to health center audiences. And I got the message. I'm sorry, I know interpretation is happening, so I will slow down a bit. Okay, next slide. So we've set forth these learning objectives for the session, and we're hoping at the end you all as participants will first of all be able to define the structural competency framework and these key concepts around structural violence, structural racism, and structural vulnerability. Secondly, hoping that you can analyze how health really is influenced by these structural factors. And lastly, to conceptualize how to deliver care and really advocate for your communities, your patients, using this structural competency lens. Next slide, please. So like I said, we're going to be looking at the structural competency framework, and this is a way to, again, really try to understand social determinants of health and health disparities. So we are going to share a lot of definitions and concepts, but at the same time, I want to set a foundation for you to understand where we're coming from with our structural competency work. So I want to share that, for us to do this work, it's because these are our principles and values, and things like we believe in health as a human right, Black Lives Matter, We believe in science, but as well as that, we also give value to lived experiences as well. That health equity for us really means fighting for healthy and dignified lives. That we see the alignment between public health principles and social justice principles. And lastly, to really wrap it up, we're going to have discussions. There's, a lot of what we're discussing has a lot of emotions tied behind it, as well as a lot of opinions. But I just want to wrap it up with this quote from James Baldwin that states that we can disagree and still love each other unless your disagreement is rooted in my oppression and denial of my humanity and right to exist. With that, can I just get to the next slide? Yeah. And then finally, in any kind of learning space, whether it be in person in like an all-day training or at a conference workshop, or how we're doing it here today, virtually via Zoom, our goal really is always to create a space that is safe and comfortable for folks to learn. And, oftentimes we hear folks say, hey, this is a safe space. And that's important to recognize and acknowledge that. But just by saying it doesn't make it a safe space. So for us, it's something that we all have to do together collectively to create a safe space. And we can do this, especially when we're talking, when we're having conversations around things like structures and structural racism, that we can create the space by acknowledging these different things and be in agreement around it. So first of all, I want to mention is positionality. And what I really mean by this is that your position is often shaped by different things like race, ethnicity, your gender identity, your sexual orientation, your class, your social class, your nationality, your own lived experiences, your culture, your language, all of this stuff. And all of this stuff, these different factors really contribute to how you get treated and are perceived even on a daily basis. And so depending on your social position, it really lends itself to giving you power and privilege. And with that position can create these blind spots. So, blind spots are things where, when a problem doesn't affect you, you don't really think about it. And I want to acknowledge that all of us, no matter who we are going to have blind spots. But it's important for us to recognize these blind spots, because if we don't, then we have this unintentional action that we can harm others. And so that's one thing I want us to keep in mind. And also that in discussions, there's a lot of stuff we're going to be presenting, but we know hopefully there's some dialogue that we'll be able to have, especially in the breakout rooms, that it's always important to remember that position where you are, your blind spots, and in these discussions, know when to take space and when to save space for others. Another thing I want to mention is that, any kind of work around structures or even anti-racism training is that it's a lifelong process in your learning. So Liam and I, we're presenting, but we don't claim to be experts, but we are very passionate and committed to things like health equity and social justice. So, we're sharing what we know with you all, but we all also are learning together with you. Another thing to add to this is that oftentimes in these kind of conversations, especially when we're talking about things that relate to racism, like structural racism, or, we'll get into white supremacy later on, that a lot of this kind of work has often been put on the communities most affected by this stuff. So communities of color, BIPOC, and it's hard, it's exhausting, and it's unfair to put all that, what we call emotional labor, on them, on us. So something just to remember when we're in these spaces, to keep that in mind. And again, remember that, folks can give lived experiences, can share a lot of information, but also it's not everyone's as a person of color to always be doing the teaching. So we want to, again, remember the save space and take space. And then lastly, just, the work that we're doing here and what we're sharing with you, it's not new. And it's really been because of the work that's been done before and the work that's continually being done, especially by the BIPOC community. And it's their leadership and activism that really has gotten us to have these conversations, gotten us to get this information out there, and also move things forward. So we want to recognize that. So given all of that, we welcome you again, and I'm going to turn it over to Liam to start the session on defining structures.
All right. Thank you, Sonia. I really thank you and applaud you and welcome you for everyone that is joining us. We're going to start here by giving you a definition of what we mean by structures and structural competency, and just give you kind of the foundation for what this work is hoping to build. So I want to start with this quote, and this quote can be very powerful, and I think that it's really important for us to think about this, especially for those that are working at community health centers. This quote from Barbara Major is, "No one has a right to work with poor people unless they have a real analysis of why people are poor." I'll give you 5 seconds just to let that sink in. So we use this quote to reinforce something that Sonia said in the introduction. What we're working for and what we're working towards is to have a framework and a lens that we're approaching our patients with and approaching our community with, to be able to be better advocates for them. So this is not to take away from any of the work that anyone is doing currently, but it's a challenge to look further and try to get a deeper analysis of why people are poor and why people are sick. And often those things go hand in hand, as I'll demonstrate in a second. So when we think about the health of our communities, often we think about their health outcomes. And we understand that there are grave, serious health disparities that exist in this country. Some of the examples, like maternal mortality, where in Black mothers, the disparity here is that Black mothers face much higher maternal mortality, even when we are looking across income levels and other sorts of status levels. This also comes with chronic conditions such as diabetes and hypertension, that different groups face worsening rates of chronic conditions. And then, of course, with COVID-19, over the last year of this pandemic, it's really opened a lot of people's eyes to terrible health disparities that exist across a lot of different groups, but especially race, where we're seeing lots of Black, Brown, and Indigenous communities face much worse outcomes when it comes to COVID-19 disease prevalence or death. And so in healthcare and in a lot of conferences such as this one, we're starting to recognize more and more where I would say it's fairly commonly accepted now to understand that our social situation does have a big impact on our health outcomes. So the social determinants of health, hopefully it's a term that most of you are aware of now, where factors such as housing access, access to transportation, income levels, job access, education, are correlated to health outcomes for certain groups and in certain communities. But what this presentation today is looking to demonstrate and help us gain a shared language around is that there are factors that have created these social determinants of health. The situations why these social determinants of health are impacting health outcomes are can be traced to these greater forces and these deeper factors, such as policies that have influenced a lot of these social determinants, the economic systems in place that have created these circumstances, as well as social hierarchies, such as racism, that have created the circumstances that have led to social determinants of health and created these vast health disparities. And so the policies, economic systems, social hierarchies, that's what we're talking about when we're talking about structures. That's what we mean when we're talking about structures. So all of this combined, how these big structures lead to poor health outcomes, that's what the concept of structural competency is getting towards. And one way that might make it easier to understand, if you're aware of the social determinants of health, we can think of this as the structural determinants of the social determinants of health. So the structural factors that created these social determinants of health. So let's look at an example here. So you'll see this map. We love these heat maps of all the counties in the US and the prevalence of diabetes by county. The darker the color here is the higher the prevalence of adults who have diabetes. And so if you'll notice, just from first glance, the darker red counties are existing more across the Southeast. To explain this a little further, or to look at another map, we can see that persistent poverty, so that means counties where 20% or more of residents are living in poverty across 4 decades, so from 1970 to the year 2000. All these counties that are in red and dark red, these are counties experiencing persistent poverty over decade after decade. And so if you were able to put these maps one on top of another, you can see that there's definitely a correlation here, that these counties with persistent poverty are also experiencing higher rates of chronic disease, or in this case, of diabetes. And so we know that income is playing a role, that poverty is leading to, or at least correlated to, higher prevalence of disease. But what we want to do is know more about why this is happening. And that's what we're doing here with our structural competency work. And this also comes when we're talking about COVID-19 risk. And when you look at this map, another heat map with the counties, the darker red counties here are those that have a higher health risk when it comes to COVID-19 of experiencing severe disease or death from contracting the disease. So again, when we're thinking about those that are most at risk and those that most need protection, we can see that it's very correlated to the same areas that have historically been living in poverty, or historically have been marginalized for a variety of reasons. And we want to know why, and we want to be able to have this conversation in this shared language to understand why. So as we look at these maps, compare the 3 of them, we see that there's a lot going on in the same areas over different diseases and over different social determinants. So again, with structures, we're looking at the policies, economic systems, and other institutions that have produced and maintained modern social inequities, as well as health disparities, along the lines of social categories such as race, class, gender, sexuality, and ability. Part of the reason why we're doing this session and why we've continued to do this session at conferences, through webinars and leading trainings on this, is because this is something that is not talked about as much as it should be. We're much more likely to talk about the implicit biases through our health promotion mindset that looks at health outcomes tied to behavior, tied to genetics, or even sometimes tied to culture. But what we want is to get a better analysis and a zoomed out analysis of how policies, economic systems, and institutions are also impacting patients' health. But that can be sometimes harder to see and harder to understand. So with this iceberg image, those health disparities that are at the top are easier to point to. And that's why sometimes it's easier for us to point to individual behavior, for example, of why, for example, with the diabetes map, often with diabetes, we point to, oh, well, people are making poor decisions about their diet, or they're not getting enough exercise. And so we're assigning that to the individual. We're now more able to look at social determinants of health to also understand, well, there are communities that live in food deserts where they don't have access to healthy food, or their neighborhoods aren't safe to go out and do exercise. And so we're starting to broaden our lens. But the deeper portion that's much harder to get an analysis of and much harder to see is this structural level. So these policies and systems that are creating these circumstances to begin with that make it so difficult to correct and improve these health disparities and improve health outcomes. So what might be easier for you to understand is if we look at it through a case study. So this is an actual patient that was brought into San Francisco General Hospital. And what I'm going to start with is this patient's medical note. But we have the luxury of knowing more about this patient beyond their note, thanks to anthropologist James Quesada, who did a study about day laborers in San Francisco. So the standard medical note, and this is in an emergency department, is just capturing the quick, basic information that we can know from a patient. So as I'm reading this, I want you to think about some of the language that is used and some of the ways that the person taking this medical note is referring to this patient. So what do we know? We know the patient is a 37-year-old Spanish-speaking male found with loss of consciousness. He's known to be a frequent flyer in the emergency department, well known for alcohol-related trauma. His past surgical history, well, he's known to have had an orbital fracture due to an assault, but there was no operative intervention taken place. Social history, heavy alcohol use, other habits are unknown, but he is apparently homeless. He's non-compliant with all medications. He was discharged last time on certain medications, but is not thought to be taking them. And in terms of his mental status, he seemed to be muttering in incoherent Spanish and inconsistently able to answer yes or no or follow simple commands. So take a second now and think about what are some of these terms that are used or the ways that that he's being referred to. So, like I said, we have the luxury of knowing more about this story. So often from just the medical note, we know the basics. He is a heavy alcohol user who was brought to the emergency department after being found unconscious in the street. This isn't to demean those that are working in hospitals and the person, like in this example, taking the medical note, because they have such limited time, are very overwhelmed by a busy emergency department, and have so little that they're able to address in that brief moment. But that's part of the system or the structure of our current healthcare system, the way it's set up. So unfortunately, we don't get to know more about the patient in that brief interaction because of how our healthcare system operates.
Liam?
Yeah.
Can I share some of stuff that folks have chatted in regarding your question about language used and the medical note?
Please do, yeah.
Okay, so yeah, thank you everyone for responding. And I'm seeing things like what really stood out for folks in the medical note is Sorry, I'm going to start my video too. I hope this doesn't take up too much. And what I'm seeing here is like we're seeing things like usage of language like non-compliant, habit, frequent flyer seems in someone's opinion to be a disparaging way to describe a patient, trying to understand what they mean by incoherent Spanish, meaning incoherent to whom. Again, this non-compliant, and then just this labeling again of frequent flyer, and just this overall feeling that there's some of the way that language is used gives a negative connotation, asking if questions if interpreter was provided, and getting any kind of trying to do a like assessment around mental health issues. And someone is stating also that perhaps the way that things are written, and it was almost implying that you don't want to waste your time helping this person. So yeah, that's a lot. And thank you for sharing that with us.
Yeah, thank you so much for sharing. Thank you, Sonia, for jumping in. As I share my screen, it's pretty difficult to have the chat box up. So Sonia's going to be monitoring that from time to time for participation. So yeah, non-compliant with medication. Well, has anybody followed up? Has there been a social worker involved to help increase his compliance? Apparently homeless. Well, who's making that judgment? Have they actually talked to him about his housing? Frequent flyer. Yeah, that means, oh, well, it's not even worth really spending much effort on him because he'll just be back. So there's a lot of terminology used. Again, I don't want to demean how this medical note happens, because it's a typical medical note that is done in any average hospital throughout the country. But what we want is to expand how we treat our patients and look at our patients and the way that we refer to them. And so we can know more of the story. We know that this patient was originally from the state of Oaxaca in Mexico and was a fourth-generation corn farmer. As cheap corn comes in from the US, he couldn't make a living as a farmer anymore and moved to San Francisco, where he had friends and family living in San Francisco, and he begins working as a day laborer. He experiences an injury at work where it prevents him from continuing to work. When he can't work, he can't pay rent in a city with extremely high rent rates. Therefore, he has to move out to the street. When he's on the street, he begins drinking more heavily. He's assaulted while living on the street, which leads to more heavy drinking to deal with the trauma, which eventually brings what we know in that medical note, where he arrives in the emergency department unconscious. What we want to know about his story, or what we can do now using his story, is understand how did structures play a role. So let's look at the very beginning. He's from Oaxaca. He's a fourth-generation corn farmer. There's a legacy of colonialism, even in Mexico, and marginalization and violence against indigenous communities, where they don't have the same opportunities, especially economic opportunities. And many see farming as potentially the only opportunity to make a living and provide for their families. With the North American Trade Agreement, NAFTA, that happened in the 90s under Clinton, it created a circumstance where corn was so heavily subsidized in the US, it was actually cheaper to import corn from the US into Mexico than actually buy corn from within Mexico, which put a lot of farmers out of work. It created a mass migration to the US. And in the US, we have a very strict and very controversial immigration policy that makes it really difficult, especially for somebody who comes undocumented to the US. We also have racist and racialized low-wage labor markets with limited opportunities for somebody in that circumstance to find work and work with protections and benefits. One of those biggest protections and benefits is access to health insurance and a US healthcare system that is incredibly complicated and has a lot of barriers for those who don't receive access through their employer or who don't have proper immigration status. We have rampant gentrification here in the San Francisco Bay Area, where Sonia and I live, as well as a lot of metropolitan areas. So city and federal policies make it really difficult to afford to pay rent, especially in a low-wage labor job. And basically, sorry, I thought I had one more there, but has basically led to a lot of the poor health outcomes that this patient has faced and made life very difficult to be able to withstand an injury at your work, or to be able to come to a new country and thrive and succeed and live a healthy life. So here are some examples of structures in red that have contributed to this patient's health outcomes. And we're going to give you a chance to come up with structures and apply this lens to a different example coming up. Sonia, is there anything else in the chat before I pass it back to you?
No, but I appreciate that. I think we have some dialogue going on, and I'm glad that, and thank you for sharing. Someone share the resource, and keep that up, but also keep in mind when we talk about our safe and comfortable learning space, all the stuff that we did mention there as well. So yeah, thank you, Liam. So let me go on. So now I think you've gotten a good overview about structures and its impact on health outcomes. And so I want to really build upon that by looking at these concepts of structural violence and racism. But in order to really understand structural violence, I think we need to be clear about what we mean, as well as in what context. So violence itself is a concept that is a little difficult to define, but there is a common theme that we have found in the different definitions, and it's that violence is something that is an unwanted, detrimental force that causes physical, emotional, mental, as well as social harm. And I think one thing that we're most familiar with is this interpersonal violence, where violence happening between individuals. And we may have been witness to it, we may have treated it, or we may have even experienced it ourselves. And with interpersonal violence, we see this like almost automatic reaction of condemnation, of stating it's morally unacceptable, that it's despicable. But when we start thinking more broader about communities and populations and their vulnerability to experience violence on a larger scale, that's when we're really looking at what we mean by structures, and how it creates ways in that some people over others experience harm, and really what creates that vulnerability and that risk, and really the large scale impact that it has on society. So because structural violence is something that's less recognizable than, let's say, like interpersonal violence, it's always a little harder to notice or recognize the larger impact that structural violence can really have. So Liam, can you go to the next slide? So we're providing you with a lot of definitions here. So this is a definition of structural violence provided by Dr. Paul Farmer. And if you know of him, he's a well-known, he's a medical doctor, anthropologist, as well as an advocate of poor people around the world. And here he's defining structural violence as it's one way of describing these social arrangements that put individuals and populations in harm's way. And so these arrangements are structural because they're embedded in political and economic organizations, it's in the way that we organize ourselves around these political and economic systems of our social world. So they're violent because they cause injury to people. If you can go on to the next slide. So we can see the manifestation of, we can apply that definition of structural violence to what we've seen happen with the Oaxacan corn farmer. And as we've identified these different structures there, we really can see how these structures came into play to cause harm to this patient. In addition to all these different structures, we saw the harm in terms of the trauma of migration and separation from family, the trauma of being unhoused, living on the streets, and then getting assaulted, drinking heavily, and then losing consciousness, and ultimately ending up in the ER. And so I think this case is one of many manifestations of structural violence. If you can go on to the next slide. So Liam, back in his part on structures, showed you how we define structures, meaning we're really looking at policies, economic systems, as well as these social hierarchies, and gave the example of that meaning racism. So before we go more into structural racism, I think what's really fundamental to that is understanding white supremacy and looking at it as this ideology, first of all, that really looks at, that believes in white superiority and entitlement. And so whether it be conscious or unconscious ideas, because of this, there's this tendency now to center whiteness. And so that becomes the normal standard, and we see it ingrained everywhere. And so, we can see this again, in what's happened in Georgia last week with the killings of people at the spa who were mainly Asian, and how there was a tendency to humanize the person who killed over 8 people. And so another thing, though, about this white supremacy of the centering the whiteness, we also saw how it was portrayed, where the shooter, again, was someone who was more humanized, rather than looking at the larger issue and looking at those who died from that shooting. And then, in addition to that, what we're seeing with white supremacy is that it's ingrained, like I said, in all our systems and in society as a whole. So we're seeing it in the political, economic, and social system, where one group mostly has the power, control, and resources. And this one thing I want to point out too with white supremacy is that because, like I said, we're centering it and it's become the norm, that folks who are non-white, people of color, can also internalize it and help perpetuate it as well. If you can move on to the next slide. And as you can understand, that something like, in all of these stuff that we're covering, when we just look at the different structures that we mentioned, and with something like white supremacies, there is a lot of nuances and distinctions. So we don't have that time to really delve into that further today. But I do want to just point out that, and this is from an article written by Angela Smith, and really looks at what she calls the 3 pillars of white supremacy, and how these 3 concepts can really help uphold white supremacy. And it's just organized around things like slavery, and where slavery relates to this really dehumanization of the Black body and looking at it as property. And then you have this pillar of genocide, where the erasure of identity. So we see it most what's happened with indigenous communities, and this concept of Orientalism, where it's creating that other concept, right? And so comparing one civilization and other cultures and countries and civilizations as less, as inferior, and that creates this thing around xenophobia. there's a lot to unpack there, I know, but because we don't have that time here. But at the end, I think we can share with all of you some resources, and you can delve further into this. Can you move on to the next slide, Liam? So so one manifestation, we've talked about structural violence and white supremacy, is structural racism, which has had a very detrimental impact, especially in the US. And similar to violence, racism is something that's more identifiable when we see it on that interpersonal, individual level. But when you look at it with a structural lens, you can see the far-reaching impact that it has. So here, this is a quote from Kwame Ture, or many folks know him as Stokely Carmichael, who was a very prominent civil rights activist. And he writes, he's comparing what we call the individual, and then here he calls it institutional, but we feel that that is analogous to structural, the comparison of those two. So let me read it out to you. And I remember, I will try to read it slowly because we do have interpretation going on. So with structural racism, that racism is both overt and covert. We call these individual racism and institutional racism. The second type is less overt, far more subtle, less identifiable in terms of specific individuals committing the acts, but it's no less destructive of human life. The second type originates in the operation of established and respected forces in society, and thus far receives less public condemnation. So institutional racism, or like we're referring to as structural racism, leaves individuals and communities destroyed and maimed physically, emotionally, and intellectually because of conditions of poverty and discrimination in the Black community that is a function of institutional racism. Do you want to move to the next slide? So one contemporary example of structural racism is mass incarceration, or which has largely been framed around this idea of the war on drugs. And so here's a chart of incarceration in the United States. So if you look at it, you can see that from the late 1800s up until about 1970s, that it was pretty steady, the rate of incarceration. And then starting in the 70s, just this dramatic increase of incarceration rates in the US. And one thing that we know is this wasn't done by accident, and it wasn't a result of an increase in crime, and that we also know that it didn't affect all groups equally. If you can go to the next slide. So this infographic is from the Sentencing Project, and it looks at the likelihood of incarceration in someone's lifetime. And if you can see here, the disparities that exist is that it states that for Black men, 1 in 3 have a likelihood of being incarcerated in their lifetime. For Latino men, you have 1 in 6. And so looking at that and compared to white men who have a 1 to 17 likelihood of being incarcerated. So this disparity, you're also seeing the same patterns that happen among women. So you're seeing the same for Black women and Latinas compared to white women, but also you're finding that women are being incarcerated less than men are. Next slide. So, like I said, that this when we see this like increase in incarceration rates, that it wasn't an accident, and to really understand structural racism at play within our criminal justice system, I want to share this quote from John Ehrlichman, who was a Nixon advisor. And so this reads as: the Nixon campaign in 1968 and the Nixon White House after that had 2 enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. So we could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. You want to move on? And I think what this shows is that there was a deliberate strategy used to really undercut, in this case, the Black community in the United States. So another example of structural racism is redlining. And so for those who are not familiar with redlining, that redlining is this practice that financial institutions use that excluded Black and non-white families from being able to invest their savings into purchasing homes. And so certain areas that were predominantly non-white households, Black families, non-white families, were redlined and ineligible for favorable loans. And areas where you saw mostly white families living, were deemed eligible for these more favorable loans. And so what we have here on this slide is, if you can go back, Liam, is a slide of Oakland, Berkeley, where we are in California. And you can see how things were categorized here, red being that fourth grade, if you look at the legend, and green being that first grade. And again, this legend around, this is also from Philadelphia, of what was, whatever is red line is being called hazardous, and what was identified under green is called best. If you can move on to the next slide. And so, that practice started in the 1930s, and to see the long lasting impacts of something like redlining, we want to look at some data around housing. And something I didn't mention previously around redlining is that home ownership was a way that families were able to build generational wealth. So meaning to build wealth that they could pass on from generation to generation post-World War II. And this was something that was not afforded, these opportunities to generate wealth to Black and non-white families. And so when we look at the lasting impacts, here is data now about housing. So there are two indicators here. First of all, we're looking at the percentage of severe housing cost burden. And I think you can see that on the left side. And so severe housing cost burden really is about the, if you spend more than 50% of your income on housing. And so you can see here that they're looking at it by race and ethnicity. So you have American Indian, Alaska Native, Asian Pacific Islander, Black, Hispanic, and white. And so when you look at the data that's presented here, you can see for this housing cost burden that Black families are over 30%, whereas compared to white families, I believe they're about 17%. And then on the other side, when you're looking again at home ownership rates, you're seeing kind of an inverse of this data where in terms of home ownership that you're seeing about, I believe it's around 34% or so for Black families in terms of home ownership, but for white families, it's I believe around 63 up to 70%. So we can see the long-term impacts of something like a practice like redlining has had. If we can move on to the next slide. And again, just another example of redlining, and you can see this was for Denver, the Denver area. And if you compare that now to data around things like hospitalization rates for COVID, as well as percentage of residents who don't have health insurance, you can see similar patterns from what previously from redlining until present day. If you can go on to the next slide. And again, in addition, when we're thinking about COVID, here is information about the death rates. This data is actually from June to December of last year, and that we can see that for Indigenous, Black, and Latino Americans, that they're at least 2.7 times more likely to die of COVID than in comparisons to whites. And this is national data. And if you can go to the next slide, please. And then looking at it, that was national, and really looking at it by states. And so again, here's an example of California. And what we look at this information here is that we can see for Hispanic or Latino populations that despite being making up about 39% of the population, that they're holding higher burden of death by COVID. And you can see how it's flagged here as well. And we can see all these other percentages, but Liam, if you can just click on to the next thing. But what these percentages really mean, so by the end of February of this year, we can see that despite the lower percentage numbers that we were seeing by cases and deaths, that the Pacific Islander and Native Hawaiian population are being devastated by COVID in terms of mortality, and then also Latinos, Indigenous, Black, white, and Asian. And so with all of this, it's really important, again, that this information is being collected, that we always need this data, and we need to, even though it's good to have aggregated, we need to disaggregate it as well, looking at race and ethnicity. Liam, you can go to the next slide. And then finally, in addition to the lost lives due to COVID, we know that it's had this devastating impact economically and socially, especially on the labor force, which is essentially represented by women, BIPOC, as well as members of the LGBTQ community. And a lot of these jobs that we've seen that we've been categorized as essential are largely staffed by BIPOC and tend to be lower wage and have little minimal protection. And so, when we talk about things like structures, we also know the impact that it eventually has on social determinants of health, and that we understand that health is not just influenced by, I think Liam mentioned, just by things like biology or culture or even behavior, but really considering these social and economic factors, and something like COVID, understanding the impact that it really has and will have the lasting impacts on people's economic and social lives as well. So with that, I'm going to wrap up there and turn it over to Liam.
All right, just getting my video back up. Thank you, Sonia. And thank you, everybody, for sharing in the chat. I really appreciate that. With, let's see, 136 people. The chat can be a little overwhelming sometimes, but I appreciate everybody's participation and involvement in the discussion that it's bringing up. Just ask you again, if there's anything about the content itself that you question or would like to discuss further with us, that we're really happy to do that with you outside of it. So just, yeah, any chat things, just please direct it towards Sonia and I. So we're going to give you now a chance to actually apply some of what we've been talking about to an actual case study. So this is a different case study. In this one, again, this is a real patient. And what we know from this patient's medical note is the basics. Same thing with our corn farmer from Oaxaca, is we know that this patient was taken from a Burger King due to altered mental state, and she has uncontrolled diabetes. She's brought to the emergency department, where she has a myriad of issues. mainly due to her uncontrolled diabetes. But we want to know the backstory, and we want to know more history about her. So again, we have this great timeline to understand where she is coming from and how she arrived in the place, in the situation, to be in the emergency department in the first place. So what we know is that she is born and raised in East Oakland. Her family had moved there from Oklahoma 2 generations before her. She worked as a veterinary technician after high school, and her husband worked as a security guard. They have 2 children, and when her children are born, she stops working in order to take care of them. While her kids are growing up, she becomes obese and develops type 2 diabetes, but she's able to control it on metformin, on medication. Her husband dies suddenly from a heart attack at age 53. And now, since her husband was the only income, she now has to look for work for the first time in 20 years. She's unable to find work, and she can't pay rent, and she begins living out of her car. She's still able to see her primary care physician because of the county that she lives in and the county health system, but her A1C begins climbing. So her diabetes, her condition begins to worsen. After 2 years, she's able to find housing in a city called Tracy, but Tracy is in a different county than Oakland. And in this county, there's no county health plan, no county health system. And due to the overwhelming Medi-Cal process, she's unable to get a new primary care physician or see her old one. Her diabetes worsens, her conditions worsen, which ultimately leads her to having this altered mental state and arriving in the emergency department. So what we're going to do now is divide into breakout rooms. We're going to be about 5 people per room. And what I want you to do is try to think of the social, political, and economic structures that have contributed to this patient's health outcomes, and try to understand how these structures have caused harm. One person for the group should be a note taker. It doesn't have to be formal, but we want to come back together and share at least one structure within the full group chat. We understand that there are certain people that prefer to speak Spanish. We are hoping that in your groups, if you are bilingual, you can help translate. If not, then for the person who does speak Spanish, you can leave the room and come back to the main room, and we'll find a different room for you. Also, there is a handout with all this information on the session's webpage. So if you need to refer back to the timeline of the patient, you can look at that handout on this session's main page. All right, thank you. So we have a few more people coming back. I'm sorry for those that didn't have enough time. We only had 5 minutes. And I think because of all the navigation, you know, so it felt really short. We're just gonna give a few more minutes to let everybody jump back in. And for those that have already come back to the main group, if you want to share in the chat, for those that were able to get to it, maybe just one structure that you identified in your group that had an impact on this patient's health outcomes.
Liam, I think you might be looking, but I'll also be monitoring for you as well. And I have noticed in the chat that some folks said that we recognize that it went by fast. If you want to just take a moment again to look at the trajectory of this mother with diabetes, please do that as well. Okay, so we're seeing things like, so people are mentioning economic factors like no health insurance, no jobs,
right.
complexities of our health system because of especially Medi-Cal. Some of the biases in terms of weight, of overweight in society, lack of affordable childcare and lack of true universal health care. Again, childcare, looking at the education system, I guess the norms or loss of income, especially coming out of a workforce and then trying to get back in. Policy differences between two county health systems. Again, we hearing more about lack of no universal child care. Also around possibly the pricing or kind of monitoring and regulating costs of medications.
Great. I'm going to just keep us moving here. A lot of really great structures that you've all shared. And many of them are some that actually have been identified here for us. So a lot of the economic and financial structures that were mentioned, it all starts from the beginning. Why was her family in East Oakland to begin with? Well, they came from Oklahoma during the Great Depression when economic opportunities moved a lot of people west. There were limited opportunities for working class people, especially if she only has a high school diploma. There's limited opportunities for working class in this post-industrial economy. Somebody mentioned gender norms. There's no universal childcare. That would be a structure, but also the patriarchal gender norms. We don't know. Maybe she just completely voluntarily decided to take care of her kids on her own, but it's not without mentioning that often falls to the mother in the family. The types of food that she had access to as a low-income person that might have led to her obesity or having diabetes to begin with. Being out of the labor force, somebody mentioned weight bias in terms of struggling to find a new job, gender bias as well. And then also age bias. If at age 53, you're looking for a job for the first time in many years, there's a lot of different biases that the labor market and that job access, that creates barriers to job access. Universal health care is fragmented, insufficient, no universal health care, and our system is fragmented. So from county to county, there's two different systems, and she fell through the cracks. So great participation, great examples that you're sharing. This is really just scratching the surface to looking at our patients with a structural lens. But now Sonia is going to give some examples of how we can actually create interventions around these structural forces.
Great, thank you. So at this point, I'm going to have to be honest with you. We've gotten to the part I think that is the hardest. There's a lot of stuff that we've learned and, more stuff that we could all learn. But actually now with what we know, we can understand how layered and complex it really is when we are talking about structures, how ingrained they are, and it can seem pretty overwhelming, and it is overwhelming. So like I said, we've gotten to the hardest part, that this is actually not easy at all. Knowing that just starting having conversations around this is not easy, and then actually taking action isn't easy as well. And that we know that it can't just be done alone, and it is actually going to have to be a collective effort. But I do want to mention that we're going to provide some but that first of all, that it's something that is not doable, that we can make differences, we can work at making changes. So I want to provide you with a framework around some structural interventions, and then look at some examples of recommended strategies, as well as some national examples of where we have made advances in addressing structures. So Liam, if you can go to the next slide. So this is what we call the levels of intervention, and especially if you want to apply it to something like healthcare or the health center, these look at different levels where you can intervene, where you can take some actions, and it really goes from the interpersonal, which is that in yourself, doing that reflection, doing that work, the interpersonal, individual interactions, really at the clinic, health center level, at the community level, contributing to research. We, talk about how important it is to have data, have that evidence base, as well as influencing policy. And then Liam, if you can just click quickly. And one thing I think, like I said, this is not easy. Liam, can you go back to the other slide? Thank you. That, any kind of work that we're doing around structures, and again, around this umbrella of anti-racism, anti-racist work, is that this is a lifelong learning process, and we are going to continually have to learn. And so we enter that process through a lot of humility, but at the same time, we're not promoting what we call structural humility, because although we want to look at folks on a broader level, structures are not something we want to be humble to. Structures is something that we want to work at changing and dismantling as well. If you can go to the next slide. And one way that I think can be useful for all of you who work in health centers is there's a tool called the Structural Vulnerability Tool. And it's similar to, I think, a lot of tools and assessments that are out there, most around social determinants of health. And this really is looking at folks' risk and vulnerability due to structures. And this is just a part of it. It asks questions around food, housing, jobs, things like that. But there's a section here on discrimination and really understanding that impact on the patient. And also for the one doing the assessment, it could be the provider, a healthcare worker, another healthcare worker, an outreach worker, to really do some reflection upon this. And just something I want to mention about structural vulnerability, that it's defined, it's similar to structural violence. It's defined as this risk that an individual experiences as a result of structural violence. And this is including their location in multiple socioeconomic hierarchies. And structural vulnerability is not caused by, nor can it be repaired solely by individual agency or behaviors. If you can move to the next slide, please. And so again, in the case of the Oaxacan corn farmer, and Leanne, if you can just advance here, here are some ideas of actions that could be taken. I don't want to read through all of it in the interest of time, but, and Liam, can you just advance a bit? Yeah. So just, taking into account things like some actions around the clinic level. I in the chat box, there was a lot about interpretation, or even trying to identify what language someone speaks. You're diversifying staff, as well as perhaps doing more structural competency training for your staff. Community level, looking at ways to advocate for safe and affordable housing, and at policy level, again, advocating for some just policies around housing, trade, as well as healthcare. If you can move on to the next slide. And, here, we talked about the legacy of things like redlining and really creating that that generational wealth. And so again, here looking at now the racial wealth gap, and if you make comparisons, we're seeing that the accumulation of wealth over generations is increasing when you look at whites, but when you look at Blacks and Latinos, you're seeing, again, for actually Blacks that it is decreasing, and for Latinos it's slightly increasing, but there's a huge gap when you make these comparisons between Black and Latinos and whites. So to address something like the racial wealth gap, which is a huge problem, if you can move to the next slide, please. Here are some strategies that have been suggested as a way to address some of the racial wealth gap. And one here is, perhaps providing these down payments for first-time home buyers in places that were historically segregated or redlined, advocating for universal health care, perhaps creating a postal banking system where we're using the postal system as places where people can do financial services. You see this actually happen a lot around the world. And again, using racial equity lens in any kind of policies that are being proposed that really impact things like this racial wealth gap, and perhaps creating a congressional committee and having that conversation about reparations. If you can move on to the next slide. And then, in addition to that, like I said, I know this is the hardest part. It is, this is not easy, but a lot has been done by individuals and communities that have been really working hard to push for the health and dignity of their communities. So I just want to highlight 3 of them here. I want to first start with the Flint drinking water crisis, where we know in the Flint community that there was lead in the drinking water, and the community activists had for a long time been organizing and trying to get that message out there. And it wasn't, and in order to get it moving forward, it wasn't until Dr. Mona, who's a pediatrician, started noticing also, the lead counts in her patients, and decided to do a study and then really spoke out on it. And so she used her position. Oftentimes providers are given more of that voice. And so she used that position to really bring attention to what's been happening and the work that the activists on the ground were doing around this crisis. And then secondly, we can look to the People's Free Health Clinics of the Black Panther Party. And so we know around the 1960s that, there's a lot of attention being brought to the inequities and racism that Black communities are facing. And it's really had an impact on health outcomes. And so the Black Panther Party itself had mandated that their different chapters open up these free health clinics in their communities. And these clinics would, to really address, the lack of access to healthcare. And also, there was a lot of mistrust and within the communities because of the history of medical experimentation that has been done on Black communities. And we can understand what the impact now around COVID and vaccine hesitation as hesitancy as well. And so these clinics offered your basic, sorry, I am getting a note that I need to slow down. I'm sorry to the interpreter. Offering basic healthcare services to the communities as well. And then lastly, the community health center movement. And so during the 1964, and that we had Dr. Jack Geiger and other doctors in rural Mississippi, and really seeing the need for healthcare access there. And that just really evolved into what you all are a part of, is the community health centers. And so just with that, oh, sorry, Liam, if you can just move to the last slide. So lastly, I just want to wrap up with this quote, because I think it really encompasses a lot of the ideas that we shared with you today, and to know that all of this is not new, and that folks have been really advocating and really fighting for this for a long time, and that it's always important that we keep on remembering, we notice it, talk about it, analyze it, and as well as do the work around it. So let me just finish up with this quote. It's from Rudolf Virchow, a pathologist in the 1800s. If medicine is to fulfill her great task, then she must enter the political and social life. Do we not always find the diseases of the populace traceable to defects in society? With that, I'm going to wrap up. I know we have just a couple of minutes for Q&A. And again, for our interpreter, apologies, I send that out to you. But yeah, if we have any last questions.
So yeah, just to end, we only have a couple minutes. Just want to thank the organizers, NWRPCA, NCFH, NCCHCA. Queremos agradecer a Zeke por su traducción, to Zach and to Maricel, the moderators. She put the survey, a link to the survey in the chat. So please help us out with the evaluation survey when you get a chance. And our contact information is on the page. Please do not hesitate to reach out to either myself or Sonia about any questions, anything you want to discuss further, or if you'd like to explore how you can bring some of this information into your health center, whether it's bring us in to give this type of presentation or just to talk about tips and strategies. Our website and all the other contact stuff is at the bottom. I know Maribel at one point had asked about the structural vulnerability checklist. That's something, please send us an email if you're interested in that. I don't believe we included it in the handouts, unfortunately, on our session page, but please send us an email if you would like the structural vulnerability checklist.
Yeah, can I just mention one last thing? Yeah, so we can also let us know. We have a list of resources too. And so there are a lot of learnings that we've shared with you that come from different resources out there. So let us know and we can share that with you. One last comment. I know someone had brought up, this is a lot. This is a lot of stuff and we're going through a lot right now. And that self-care is really important. And I know that's a buzzword right now, but it really is about checking in with yourself and checking in with others. And taking care of yourself. And so we have some resources and actually we're going to be releasing, it's not ready yet, something about organizational self-care and how organizations can really help prioritize and put some structure around that. But I just want to mention that, these are tough times and what we shared is not easy, like I said. So just voicing it and recognizing that it is important to take care of yourself. Because we need everyone to do this work. And so any way possible, remember that, be kind to yourself as well as to others, and please reach out if you need to.
Sorry, last thing before you go, Maricel has a closing statement to make.
Yes, thank you everybody and our session presenters and sponsor, of course, Community Health Ventures. Their generosity really made this session possible. I'd like to take a moment to draw everybody's attention to the chat box. We posted the evaluation survey for this session. I'm sorry about the translation. Please take a minute to complete the evaluation. We really appreciate the feedback. I'm gonna put it again, and I'm also gonna put in the chat box the information regarding the continuing education unit for those who are interested in it. Thank you.